Okay, everyone, welcome back to another episode, second to last episode of the High Yield Rapid Pharmacology Review. This is Mike, and you will be listening to Mina a little later on. As always, just a quick disclaimer. We are reviewing the pharmacy slides from the pharmacology course, but we are not, going over every single solitary detail. So please don't forget to look over some stuff. We're going to give you what we think is the most important information, but take it all with a grain or a mound of salt. So, this session primarily is focusing on a lot of the sex hormones. So we'll get started with the androgens. More of probably one of my personal favorite hormones, being that I am a male. I think I am a little biased, but So, quick question. 14-year-old boy brought to the clinic because his parents are concerned that he has not yet begun puberty. Laboratory results indicate hypogonadism secondary to failure of the HPA axis. Which of the following is a possible adverse effect of the treatment of this patient? Anemia, decreased libido, increased calcium deposition at the epiphyseal plates, increased serum HDL, or leukocytosis. This is actually... You've really got to know your stuff, and that's sort of why we picked this question. It's sort of like a trick question in a way. And the answer is C, increased calcium deposition at the epiphyseal plates. And we'll talk about why that's the answer as we go over some of the different things on testosterone or androgens. So, we said this last time when we talked about some of the different hormones. Very broad definitions about what hormones do, sort of giving you a basic picture. And what we tried to do was sort of highlight some of the points that come up relative to questions and concepts in pharmacology. So this isn't a complete review, but more of a way for us to point out specific facts that come up a lot in questions and tied to concepts. So, what do they do? In development and adulthood, in development they're responsible for stimulating the reproductive tract development, stimulating growth of the male sex organs, and stimulating long bone growth and other tissue growth. During adulthood, they maintain secondary sex characteristics. When we talk about the anabolic and the metabolic effects include increasing lean body mass, antagonizing the catabolism of glucocorticoids, and important to remember, they stimulate erythropoiesis. So one of the ways or lab tests, aside from testing directly if somebody is taking anabolic steroids, is looking at their red blood cell growth, and maybe you have a patient and you have some sort of primary or secondary, I forget the name, hemoglobininopathy. They have a hemoglobin of 20, and you see something like that on the labs, and it's like, that. Why? So that could be a pointing factor. Metabolic factors include increasing clotting factors, decreasing hormone binding and other carrier proteins, and then finally a decrease in HDL. So, how do they work? There are three important ways in which androgens affect our body. Not necessarily work in and of themselves, but affect our body. Number one, they are androgen receptors in the body. These are nuclear receptors. Androgen is a steroid hormone, or there are steroid hormones, testosterone in particular, crosses into the cell membrane, doesn't act on the cell membrane, but crosses into it, goes into the nucleus, and activates transcription factors. Testosterone is also converted into dihydrotestosterone, DHT, in our tissues that express 5-alpha reductase. So this actually has a higher affinity for those same androgen receptors and can cause some different effects on our specifically skin, bone, liver, and urogenital tissues. Finally, the last thing that can happen is in tissues that express aromatase, testosterone can be converted into estrogen. And now that is sort of the answer to our question, because as we'll see on the other side, estrogen on the very bottom part, we remember that estrogen is responsible for closure of the epiphyseal plates. And so therefore, if we're treating that 14-year-old boy with testosterone for hypogonadism, there's a possibility that we could actually stunt his growth by causing premature closure of his epiphyseal plates, because some of that testosterone is being converted into estrogen. So that's why that was the answer to that first question we talked about. Some other very basic effects of testosterone and dihydrotestosterone. So testosterone on the internal genitalia is primarily working on Wolffian duct development during gestation, and it can also increase skeletal muscle mass during puberty and cause erythropoiesis. Important one to remember. Dihydrotestosterone is actually responsible for the differentiation during gestation and the maturation during puberty, and that's sort of where we get into those, disorders of sexual development. We have, in a woman it might manifest as primary amenorrhea, and so you have problems. You have 5-alpha reductase deficiency, and so you never differentiate your external genitalia, and you present as a phenotypic woman, but internally you have two undescended and undifferentiated testes. So this is some of the ways that they can trick you and ask different questions about different sex hormones. Finally, it also, very important point, is responsible for increased hair growth during puberty. And then oddly enough, when you get older in age in males, it's actually responsible for hair loss. So we have some drugs that are anti-dihydrotestosterone to inhibit hair loss. So some of the androgen products, we have natural testosterone, and so this actually undergoes extensive first-pass metabolism, being, going into hepatic circulation and being dissolved by the liver, or metabolized by the liver. Therefore, we don't really give this medication orally because there's not enough of it to actually get into our circulation. Therefore, we give it transdermally. And then, of course, we have to tinker with it so we can give testosterone in different ways. So they esterified it, put an ester group on that nice little steroid, and we came up with testosterone saponate. And this is actually able to be given in an IM depot administration, the depot administration being an injection that's intramuscularly given that can last 10 to 30, I don't know the specific number, but it can last over a period of time and slowly be released. Finally, we were smart enough to substitute on the 17th carbon of the steroid ring an alpha derivative. I forget what we put on it, but we can substitute and make changes to this portion of the steroid and reduce first pass metabolism to the point that we now have an oral agent. So the 17 alpha derivatives are listed below: nandrolone, extandrolone, methyltestosterone, and danazol. So these have very high oral potency, and can be given orally. And then that last little thing, just want to remember, these are very liver toxic. So very important to remember that these can cause spikes in LFTs and liver failure and all these different things. So it's another thing to watch out for. Some other effects that you can have from taking androgens. So masculinization of children and women. That's why we sort of have our next slide. Never touch females never touch testosterone products. When I was in the pharmacy, it was always, because it's a steroid, there's a theoretical possibility that, you could touch this pill and it could be absorbed through your skin, and, God forbid you're pregnant, or, nobody knows what's going on. So just stay away. Don't touch testosterone products. So, you have a transdermal testosterone that your husband, boyfriend, I don't know, somebody is taking for low T. If they administer that with their hands after they put that gel on and then wash their hands, and then somebody comes up and gives you a hug, you could absorb some of that testosterone. So you just always have to be very weary about counseling patients on using that, and you yourself just watching out, because can absorb some testosterone, possibly transdermally. Stimulation of prostate hyperplasia, as we all know. You can get a little BPH from testosterone gynecomastia, acne, erythrocytosis, sodium and water retention. So one of the issues why men, before women have menopause, are at such high risk of cardiovascular disease is because testosterone in and of itself will decrease HDL and increase LDL, which is the exact opposite direction we want it to go in. As I said before, the 7-alpha derivatives are very liver toxic, so you can have some jaundice and liver tumors. And as we all know, behavioral changes, including aggressiveness and dependence. So when you think of the side effects of androgens, just really, think about that, weightlifter in the gym who's using steroids and he's got acne and he's not getting the, his pecs are not turning out the way he wants them to because he's using too much testosterone and, he's being aggressive. And as I said before, ladies, please don't touch testosterone products. So a few uses for androgens. Obviously, of course, number one, primary hypogonadism, failure of the genital organs to create testosterone. So we can give any number of testosterone products for that. A few more niche things: weight gain and cachexia, oxandrolone sort of carries a unique indication for this. Anemia and renal failure, you can use nandrolone. And danazol is actually used quite often in some gynecological disorders, endometriosis and fibrocystic breast disease. So this is a way to actually suppress FSH and LH. So you sort of cause negative feedback by giving testosterone. So by giving the testosterone, your pituitary gland is sensing, oh, there's enough of this sexual hormone in the body. I don't need to continue to release FSH and LH to stimulate this. So it can cause regression, atrophy of the ectopic endometrial tissue and breast tissue. And then lastly, sort of, again, very niche, hereditary angioedema. Reduces attacks associated with hereditary angioedema by increasing levels of C4 complement. Most of those things on this page are a little nitty-gritty. I think I would remember danazol and the gynecological disorders. That may come in useful. I do remember seeing a question or two about that. And of course, understanding, primary hypogonadism is, the primary use for androgens that you're going to see. So now we, of course, move on to, if we have agonists, you better believe we're going to make a few antagonists for some reason. Here we have flutamide, bicalutamide, nilutamide, and spironolactone. So these are all competitive receptor agonists of the androgen receptor, primarily used in prostate cancer. And as talked about before in our previous lecture, the main treatment of prostate cancer is going to be from our GnRH agonist, causing a block, actually, of the release of FSH and LH in the pituitary gland. But these can be used in combination with that. They're all administered orally. And one of the things that you just want to make the connection in your head, testosterone agents, agonist or antagonist, they're just not good for your liver. So carry forward and string together that adverse effect of hepatotoxicity. Moving a little bit further, so we have an androgen synthesis inhibitor, finasteride. Now this is what we were talking about before. This is our 5-alpha reductase inhibitor, and so this inhibits the production of testosterone into dihydrotestosterone. And there are two primary uses for this. BPH, because that, as we remember, the prostate expresses a lot of 5-alpha reductase, and its increase in growth is actually thought to be primarily due to dihydrotestosterone. So we can actually give, in more benign cases, 5-alpha reductase, also in combination with an alpha blocker or a GnRH agonist. In addition, it can also be used for alopecia or male pattern hair loss. It's thought, as I was explaining earlier, that a male pattern baldness is secondary to dihydrotestosterone. When we're young, it's good and it helps us grow hair. However, as we get older, the physiology for whatever reason switches, and it actually becomes a problem, and it causes hair loss. So we can give it for that. However, as you can see, when you're obviously screwing around with some of your testosterone hormone, you can have some effects like impotence, gynecomastia, and a decreased libido. So you can see why, even though you're trying to keep your hair, for whatever reason that may be, you keep it because of the things that the adverse effects are actually going to cause you to have. So, maybe you'd rather lose your hair and still be, still have a libido than to have your hair and then have no libido. All right. So now we'll move on to estrogens. All right, quick question. A 23-year-old woman comes to the physician because of severe abdominal cramping, menorrhagia, and low back pain correlating with her menstrual cycle. On pelvic exam, the physician palpates a nodular enlarged ovary. Exploratory abdominal laparoscopy reveals multiple lesions on the exterior of the ovaries bilaterally. Her symptoms were refractory to treatment with an OCP as a result of a medication that treats her endometriosis by inhibiting endometrial growth is prescribed. Well, that's nice. They told you it was endometriosis. Which of the following is an adverse effect of this medication? And the answer is osteoporosis. And so this sort of goes back to remembering when we talked about osteoporosis last lecture that estrogen is a key component in bone growth, specifically in women. There's some sort of estrogen receptors are tied to the osteoblasts. So just important to remember, especially in women that are postmenopausal, osteoporosis becomes an issue at the forefront. And if we're causing menopause by, prescribing a medication that inhibits endometrial growth, we have to worry about menopause. So again, very broad explanations. Estrogens, what do they do? So developmentally, the reproductive tract, breast ducts, and stroma, they are all involved in the development. The distribution of body fat. We'll keep hammering this home, and I guarantee you'll get a question they love to talk about this. So prepubertal growth in the long bones, but then closure of the epiphyseal plates as puberty. Always remember, involved in bone growth, but then also closure of that epiphyseal plate. Very, very important. And growth of the follicle. Also helps to regulate the endometrium, maintenance of skin structure, blood vessels, and decreasing bone resorption. And hepatic effects, increasing clotting factors, very, very, very important. Binding of proteins for estrogen and testosterone. So you will see in pregnant women that there's a little bit higher estrogen in that state, and what will happen is you will have an increase in these clotting factors and binding proteins. So you'll develop this sort of thyroid disease in the setting of pregnancy, because if there's more binding proteins, your total, I'm confusing this in my head. So if you have more binding proteins, the TSH, the T4 level or T3 levels may go down, but your total amount of thyroid protein doesn't change because it's just now binding more and it's not showing up on your lab test. So there's a lot of different things that can happen with the clotting factors and the binding proteins. Renal and water retention, loss of fluid from vasculature and extracellular space, and then lots of metabolic effects, increasing triglyceride synthesis, increasing HDL, decreasing LDL, and decreasing plasma cholesterol. So sort of the opposite things that we were talking about with testosterone, which is why we see in premenopausal women that the risk of having cardiovascular events is so much lower than men because estrogen provides such a health benefit. Now, let's talk about some of the agents. So we have our straight estrogen or estradiol. I didn't really get into the clinical or the chemical structure, but there's at the 17th carbon, there's an E2, there's a structural change. This is the most potent estrogen, but it has extensive first pass metabolism, which we talked about with the testosterone, so we can only give it transdermally. So of course our great scientists figured out, let's conjugate a little cypionate group or some other things, and we have now agents that can be used intramuscularly. Estrogen, estradiol, cypionate, estrone, and eloquin. Finally, we really got a little crazy, went into the lab and figured out, all right, we can develop ethanol, estradiol, and mestranol, and these can be taken with high potency orally. and have reduced first pass effect. The idea is that the ethanol substituted reduces the first pass effect, and the mestranol is metabolized actually into ethanol estradiol. So, great little discovery. Oral estrogen. Mechanism of action, these are binding to the estrogen receptor, which again, like the testosterone receptor, is a nuclear gene transcription. So we go through the plasma cell membrane into the cytoplasm of our cells, and we are hooking up with a receptor there and then going into the nucleus to cause some sort of gene transcription. It can also cause negative feedback, which is one of another mechanism that we can use it, or sort of a mechanism that we can hijack. By giving estrogen, we can actually suppress the release of other gonadotropin secretion, like FSH and LH, and then cause our body to secrete less estrogen. So its uses, all three different types can be used for primary hypogonadism. We can use estrogens for postmenopausal replacement therapy, the conjugated and esterified types primarily. PO means oral, so oral contraceptives, those are most like the synthetic ones, and then suppression of ovulation and dysmenorrhea, again the synthetic ones. So finally, in the treatment of transgendered persons, I probably should have put this first testosterone, but we can use this for hormone therapy as people are transitioning, and I believe after they transition as well, because they will need the constant hormone at different levels than their body creates. So some of the adverse effects. Very, very important to remember the estrogen adverse effects, even more so than testosterone, much more tested. So number one, endometrial hyperplasia. Burn this in your memory. If you give estrogen unopposed to a female, you run the risk of endometrial and breast cancer. Think about it. Specifically for endometrial, you have your 28-day cycle, the endometrium of the uterus builds up and then sheds, and builds up and then sheds. If you were to give estrogens constantly, you would not have that shedding period, and you would have estrogen continuously building up and building up and building up. And so you have this more risk of dysplasia, and then, boom, metaplasia, now you're into cancer status. So never give estrogens unopposed because of the risk of endometrial uterine cancer. This is sort of the physiological, physiological issue behind PCOS, polycystic ovarian syndrome, is you're not ovulating anymore, and you're continuously having this buildup of your uterine endometrial lining, and it's a very big problem, and it leads to having these events of you don't have a period for 5 months, and then all of a sudden you ovulate, and you do, and there's heavy bleeding that could be life-threatening. Increased risk of cholestasis. I believe estrogen hormone actually reduces your gallbladder's ability to contract. So you have buildup of the wonderful bile leading to stones. Some breast tenderness, headache, and it can specifically exacerbate migraines. It can cause feminization in males. Males probably shouldn't touch estrogen products, as I had said. Conversely, for females and male products, and testosterone products, excuse me. Stimulation of hormone-dependent cancers. So, we talked about breast cancers. This is more so making the point that, we know that breast cancer is hormone dependent for the most part. You have estrogen sensitive, progesterone sensitive, and then the last one is HER. So we have those three receptors. So if you have estrogen sensitive breast cancer, giving somebody an estrogen, that thing's going to grow. So we just have to be careful about who we give these drugs to, or this hormone to. And lastly, in high doses, it can cause edema and hypertension. And finally, estrogen carries the risk of thromboembolic disease, VTE and PE. So very, very important before you start any, a woman on oral contraceptives. You always have to ask, do they have a history of DVT blood clots? Because if they do, that's a contraindication for starting birth control. As I was talking about before, we have a couple antagonists or agonists, so now we must talk about the antagonists. So we have a few estrogen antagonists, clomiphene and fulvestrant. Very, very cool drugs, especially clomiphene. These are both receptor antagonists. Clomiphene is primarily used for the induction of ovulation. So, what? You give an antagonist. And what this antagonist does is it blocks the negative feedback to the pituitary gland. So the pituitary, anterior pituitary, is used to seeing estrogen as a way to say, okay, we have estrogen in the body, therefore I don't need to secrete FSH and LH. So if you block the estrogen receptor on the anterior pituitary, what you're doing is you're telling the pituitary, I need to secrete a ton of FSH and LH because there's no estrogen here. And that causes an increase in GnRH, that would cause an increase in that feedback system, eventually leading to FSH and LH release. Fulvestrant is primarily used for estrogen receptor dependent breast cancer. So if it's unresponsive to tamoxifen, and we'll talk about what tamoxifen is shortly, that's a SERM, a selective estrogen receptor modulator. Then we have our aromatase inhibitors. So as we talked about before, aromatase is the enzyme that will convert testosterone into estrogen in certain tissues. So we're going to inhibit that. This can be used in breast cancer, first line or unresponsive to tamoxifen, or it can be used in the treatment of endometriosis. And for endometriosis, I believe there's a component of testosterone that is unregulated in the female body, and so by using also an aromatase inhibitor, it would be a way to block an additional mechanism by which estrogen would be produced. So in adverse effects of these drugs is to reduce bone mineral density, obviously, because we're blocking the estrogen receptor, and that is tied to bone mineral density. So the SERMs, I was just talking about these a moment ago with respect to tamoxifen. This is a selective estrogen receptor modulator. So, there are many estrogen receptors in the body, and of course we've been talking about the scientists all day. We thought it would be very cool to, sort of do like we did with the adrenergic drugs. Let's activate the beta-1 receptor, not the beta-2 receptor, and get real funky with it. Unfortunately, it's not. At this point, we can't. You can't really selectively pick what you want. You're gonna hit an estrogen receptor, and it's gonna act differently at all of these different places in the body. So, tamoxifen, it modulates the estrogen receptor. And we say modulate because, as you can see over here, it is an antagonist at breast tissue, but it's an agonist at bone, uterus, and fat. So therefore, it can be used for estrogen receptor dependent breast cancer. However, it does not reduce hot flashes. That was another idea, that we could block, or we could treat breast cancer by being an antagonist there, or just treat hot flashes by being an antagonist there and not have to worry about the effects of giving estrogen and what it would do to the breast tissue. But it didn't work. However, because it's an agonist at the bone, at the uterus, it actually has a risk of endometrial cancer. And it also has a risk of DVT-PE because it is, in that respect, it has estrogen-like activities. So then came along raloxifene, which, again, antagonist at breast tissue, and so it can be used for that, and it can also be used for osteoporosis, specifically because it has a neutral effect on the uterus. So therefore, it does not have that risk of endometrial cancer. And so therefore, because that it doesn't have that risk, we're more likely to give it for something a little less benign like osteoporosis. So, tamoxifen will give for breast cancer, but because of the side effect of endometrial cancer, we're not as likely to give it for something like osteoporosis because balancing the risks out, we can give something else for osteoporosis and not have to worry about endometrial cancer. But because this doesn't carry that risk, it's a little bit, it's easier to justify that. It's very important. You got to keep this straight in your head. Tamoxifen agonist at the uterus, Raloxifene is actually neutral and does not carry the uterine cancer, endometrial cancer risk. There's a few newer agents, not very high yield. Ospemifene, it's used for dyspareunia, painful intercourse due to menopause, which can lead to vulvar and vaginal atrophy due to the reduction in estrogen. And then the last one is Basdoxifene, and so this is available in combination with conjugated estrogens, and this is for the vasomotor symptoms, hot flashes associated with menopause, and it can also be used for postmenopausal endometriosis. And so it can provide protection to the endometrium without the adverse effects of a progestin. So these are a little bit lower yields, but maybe just the little niche. No, maybe the name and what it's used for. Last but not least, we'll talk about progestins. All right, so what do progestins do? So, again, very basic explanation, pointing out facts that will be on questions related to pharmacology. So they can help differentiate uterine endometrium tissue, glandular secretions, and spinal artery development, production of thick cervical mucus, extremely important to understand progestins do that, suppression of myometrial contractions, maintenance of pregnancy, glandular breast tissue development, prevent endometrial hyperplasia, very important, respiration, they can actually stimulate respiration, that's why pregnant women have more progesterone release during their pregnancy and actually increases your respiration rate. Metabolic increases insulin secretion, but it also causes glucose intolerance. Now, the thought there is that you need more glucose to get to the fetus, so you actually have progesterone that's secreted that causes a glucose intolerance, leading to the glucose sticking around so that it will get to the fetus. But now that we eat the way we do, and some of our metabolic syndrome, you can actually have more gestational diabetes, and it can also increase body temperature. Endocrine-wise, it can decrease sodium reabsorption in competition with aldosterone, and will increase metabolism of testosterone. So, the drugs. We have natural progesterone, and then we have medroxyprogesterone, which is a derivative, primarily used in combination with estrogen for hormone replacement therapy. Secondary, amenorrhea, and ovarian suppression for dysmenorrhea, endometriosis, vaginal bleeding, and I can actually add to that, wait, nope, never mind, I won't, add oral contraceptions, because we don't use those orally. We use our 19-nortestosterone derivative, desodril, norethindrone, norgestrel, and levonorgestrel. These are our derivatives that are used for oral contraception and ovarian suppression for various reasons. How do these all work? These bind to our nuclear steroid progesterone receptor, as it was in testosterone and estrogen. Some of the adverse effects of these drugs include fat deposition, weight gain, acne, and hirsutism, or hair growth. Similar to the androgen side effects, because there are some androgenic properties of progesterone. They share similar profiles, so there are some progestins that have more androgenic potential. They decrease HDL, again similar to androgens. They can cause menstrual abnormalities. They can reduce our glucose tolerance, leading to glucose intolerance, and they can also cause uterine cramps. One of the specific ones you do want to know is mifepristone, or RU486. It is a progesterone receptor antagonist, which is primarily used for first trimester abortions with our prostaglandin misoprostol. Can also be used for Cushing's syndrome. Side effects primarily include vaginal bleeding and abdominal pain. Obviously, if we're giving this for a first trimester abortion, we're going to be antagonizing our progesterone receptor, leading to the shedding of the endometrial lining and some abdominal pain. So just some oral contraception information. I don't know how much of this, the next few slides you don't have to really know, they're more FYI, but just for this. Oral contraceptives ladies, you probably already know all this. Guys, this is for your information, because on your OB rotation, you're going to go to a lecture at Mount Sinai, and there's going to be a professor who gives you a 2-hour lecture on contraceptives, and he doesn't want to hear from any of the women. He literally, like, the entire 2-hour lecture is he goes down the line and he asks every guy in the room how this stuff works. So if you learn this stuff now, you're going to look like an all-star. So the combination pill. The combination works by inhibiting GnRH secretions exogenously. How does it do this? By supplementing with estrogen and progesterone, we can suppress ovulation. This is what we talked about before in a way with clomiphene. What we're doing is we're giving small amounts of estrogen and progesterone and fooling our anterior pituitary into thinking, it has enough, so it doesn't need to produce FSH and LH, therefore we don't ovulate. So we always give estrogen with progesterone to produce, to inhibit endometrial hyperplasia. There's also something known as the progestin-only pill. This can be given to women who have some of the contraindications to oral contraceptions or the oral contraceptive combination pill, be it PE, VTE, or clotting, migraine with aura, or women who do smoke that are over 35. Can't give them the estrogen oral contraceptive pills. These work via causing a thickening of the cervical mucus, which is thought to inhibit the sperm from entering the uterus. Now, the POP pill is significantly, I won't say significantly, there's a marked difference in the efficacy in preventing pregnancy. The combination pill is very effective. The POP pill is very effective, but it comes with the caveats of you must take it at the same time every single day, at the same exact time for the most part. If you, vary by 10 to 20 minutes, you could lose some efficacy in the progestin-only pill. The combination pills need to be taken around the same time, but you can sort of get away with maybe 30 minutes taking it, not at the same time. The efficacy is significantly reduced as it is with the POP pill. Adverse effects: high-dose estrogen can cause some breakthrough bleeding, nausea, mastalgia, breast pain, and edema. It can also exacerbate headaches and migraines. It can cause some weight gain and acne, depending on the dose of progestin and its androgenic potential. It can cause some increased skin pigmentation, increased triglycerides, and amenorrhea, which, not necessarily a side effect in some cases. There were developed some birth control pills so that, you actually would have less periods. So, side effect versus intended effect sort of a deal. And then again, very important, severe adverse effects include clotting risks because of estrogenic effects, possible MIs because of those clotting effects, and then cholestatic jaundice and hepatic adenoma. Hepatic adenoma, very important to remember. One of the, primarily, you get a 25-year-old woman coming into clinic and she, for whatever reason, stumbles into a CT and you have a solid liver mass. Part of the differential is, or part of the workup is, is she on oral contraceptive pills? If we stop them, does the adenoma go away? And so this is more just FYI stuff, talking about how estrogen is the ethinyl estradiol, its dosing, and then the different progesterone generations and the effects that they have. If you're really interested in this, you can actually look up something called a Dickey table. The Dickey tables actually were a way to determine, if a woman, the symptoms that she's trying to target with oral contraceptives, maybe trying to reduce acne or, different things. So it's actually, there's a lot of science that goes behind it, and it's actually very cool. And then finally, just a little bit more information about breakthrough bleeding, clotting risk, and again, some of the effects that we can target in providing oral contraceptives and the things that we can provide. And then finally, just a little bit of information about the effectiveness. Board test question: Nexplanon or the Nexplanon implant is going to be quote unquote the most 100% efficacious birth control pill or birth control method. Next in line is the intrauterine systems,